Hello and welcome to Brain on Fire webinar. My name is Caleb Rudd, and joining us today is Dr. Sandeep Gupta and Dr. Mary Ackerley.
Thank you, Caleb. I'm really excited about this webinar because, we've really been working with people with CIRS or mold illness for many years, both Dr. Ackerley and myself. And one of the really huge problems that people encounter with this condition is relating to the brain. And that includes things like brain fog, which means people's memory isn't working properly, people's ability to assimilate information is not working properly, they can't concentrate. And it's also extremely common to get anxiety and depression and hopelessness and a variety of other conditions pertaining to the brain. So today we're going to explore how this condition of CIRS affects the brain and how we can understand the mechanism whereby CIRS affects the brain, and then also talk about what can be done about it so that we can actually fully regain our brain's abilities and also recover from any mood disorders or any other psychiatric symptoms that patients could be suffering from. Anything you would like to start off with, Dr. Ackerley, about your experience with this condition?
My experience comes from being a psychiatrist who started to see patients who said they had mold. And as I've said before, I simply assumed it was psychosomatic as I was taught. And there was a mold doctor practicing fairly near me, and people would come to see me because they were still depressed and anxious and needed treatment and didn't want to go on medications. And at some point, I began to realize that mold illness was not just psychosomatic in the head, but that was, verifiable with labs and a reality, and you could, measure mold. And I became, I guess, a SIRS doctor. And so my experience has always been in treating people with really psychiatric and neurological and psychiatric problems, because even in the beginning, I was seeing people who were afraid they were getting Alzheimer's. And so over the years, I've seen a broader variety of patients, but the mainstay of what I see are people whose primary complaints are my brain doesn't work, I'm depressed all the time, I'm so anxious I can't sleep, I can't think about anything, and I don't even know what to do. And those encompass actually many of the symptoms of SIRS too. And so working with, psychiatric, neurological psychiatric problems has been something I've become more skilled at and knowledgeable about.
Great, thank you for that intro. We look forward to exploring that more in this call today. So could we have the slide deck back on? And next slide, thanks. Okay, next slide, thanks. Okay, great. So there's going to be a fair bit of information we're going to be covering in this webinar today. So to get the most out of this webinar, I'm going to suggest that you might care to close or minimize other web pages and browser tabs and have a pen and paper ready because there will be some new concepts discussed, although there's nothing totally new. There will be some information you may not have encountered today, and therefore it'll be worth noting down any new information. Thank you. Okay, a little bit about myself. Many of you who have had a look at the Mold Illness Made Simple course or who live in Australia will know me. I graduated here in Australia from the University of Queensland in 1999, and my original training was in intensive care in the hospitals in Brisbane, and particularly I used to look after patients who had had heart surgery or cardiac surgery and were suffering from a variety of problems after cardiac surgery. But I also looked after patients who had something called sepsis. And we may get a bit of time to talk a little bit about how the condition of sepsis actually has acted as a prototype condition for the discovery of CIRS or mold illness. I've now been on the Sunshine Coast for around 7 years actually, and with my own private holistic medicine or integrative medicine practice. And I had a little bit of a personal journey with mold as well, with a house that flooded on the Sunshine Coast. And that led me to seek out Dr. Richie Shoemaker and become the first non-US doctor to become certified in the Shoemaker protocol. And I was lucky enough to co-author the consensus statement on chronic inflammatory response syndrome with Dr. Ackerley, Dr. Bernstein, Dr. Rappaport, Dr. McMahon, and Dr. Shoemaker. Thank you, Caleb. Dr. Ackerley, would you like to introduce yourself?
Yes. So I am a classically trained psychiatrist and board certified integrative physician also, and my practice is my passion for health, and I've been the co-author on the same consensus statement, and more recently have been involved with a paper on VIP and neuroquants showing that VIP was safe and was effective somewhat in restoring, in helping some of the atrophy that we see. I've also been involved with inhalational Alzheimer's too with Dr. Bredesen, and wrote an article which has gotten a lot of play on Brain on Fire, which is my words basically on the psychiatric symptoms that mold seems to cause and cause pretty quickly.
Right, and Dr. Bredesen's work is really quite fascinating, isn't it? Looking at the role of chronic inflammatory response in Alzheimer's disease, and how VIP particularly appears to have a very promising role in reversing that, and that's very exciting, I think.
Exciting and frightening when you consider how common neuroinflammation is, if it really is the predecessor. For some people, at least to Alzheimer's. I know I get an increasing number of inquiries from boomers who are, getting to the age where they're thinking about Alzheimer's and really wondering, does my brain look like Alzheimer's? Do I have mold? Is there something I can treat so I don't get Alzheimer's? I think it's probably the most feared illness there is as you get older.
Okay, so a little bit for those who are fairly new to this condition, and for those who know quite a bit about this condition, this is going to be old hat, so just bear with us. But basically, mold illness is a colloquial term for what's actually known as chronic inflammatory response syndrome due to the indoor environment of water-damaged buildings. Try saying that 3 times fast. It is abbreviated as CIRS-WDB, and commonly we just refer to it as CIRS. This condition has been discovered and named by Dr. Richie Shoemaker, who you see pictured on the right side of this slide here, who both Dr. Ackerley and I have trained under. Dr. Shoemaker and his CIRS certified physicians, of which there's about 15, I believe, have co-authored dozens of peer-reviewed papers, which are in reasonably reputable journals as well. I mean, they're not the main journals like New England Journal of Medicine, but they're reasonable journals. And he has a whole collection of articles at survivingmold.com. Thanks, Caleb. So what happens to the brain in CIRS? And I think we can start, before we start asking Dr. Ackerley questions, I'm just going to give a very brief overview to make it simpler for you. And I want to introduce 2 terms, and they are edema and atrophy. So the simple thing is to change the word in your edema in your mind to swelling. Many of you may have heard of the term edema when it relates to your ankles. When you, for instance, go on a long plane flight and you're swollen in the ankles, medically we call that ankle edema. Now the same thing happens in certain areas of your brain due to CIRS. Now, it's particularly the front area of the brain, the forebrain parenchyma, it's called, and there's a number of other areas. They become swollen due to inflammation. Now, inflammation is a silent fire that occurs in your body. And the reason that we get inflammation in this condition of CIRS is because people with CIRS are not able to properly process mold toxins. And therefore, instead of creating a proper immune response, they develop a chronic inflammatory response, which means they develop a silent fire in their body. And that silent fire particularly affects the brain. So if you have a look at the diagram on the left side of this slide, that's a very good way of visualizing this, that the brain actually goes on fire. And then that was the name of Dr. Ackerley's article, The Brain on Fire. So that's what we're talking about in this condition of CIRS, is that we have inflammation actually physically affecting the brain. It's not just in your, well, it is in your head, but it's actually, there are actually measurable changes. And we also get atrophy or shrinkage. And there's various other conditions in which we use the word atrophy in medicine. But really it always means shrinkage. And as you see on the right side of this slide, these bushes are becoming progressively more shrunken. And there are certain areas that get shrunken in CIRS, and it's particularly an area called the caudate nucleus, which gets shrunken in CIRS. And that's another result of the inflammation that's occurring in the brain. Dr. Ackerley, would you like to add anything to that?
The atrophy and the swelling combine to make what we commonly refer to as mold brain, which is cognitive impairment, in focus, in memory, in short-term memory, the inability to assimilate new information, which is one reason this course was developed, so that people can go at their own pace and repeat these concepts again and again until they become as familiar to the patient as they are to the doctor, who's kind of rattling them off, needing to get through a full hour of treatment too. So that's where it may be very familiar to people, is in the assimilation of lots of new information quickly is very difficult with the kind of atrophy and swelling we see. And the swelling in particular affects the frontal lobes, which is, you can realize by their name, they're very close to the nose, and inhalation is going to occur through the nose. So because the blood-brain barrier is most likely, I think the best word really is leaky, that you can understand. It's hyperpermeable. It leads to this microvascular cerebral edema seen usually only with neuroquant, not on just the normal scan read by the radiologist. And it's that inflammation or swelling of the frontal lobes that leads to some of the executive functions being impaired. And the executive in the brain focuses and organizes, and that's something that can be really difficult for people, certainly in the beginning stages of the illness. It's also the emotional regulator of the brain. So you have a limbic system generating a lot of emotions and impulses, and it's the executive who listens to them and says, stop, we can think that, but not say it, because it's going to have consequences down the road if you tell your boss what you really think of them, or tell your wife, etc. And it's that lack of emotional regulation, which can be seen as rage or just irritability, that often characterizes some patients.
Right. So if someone's suffering with this condition and they find that they're a bit more emotional than normal, and they're saying things to their partner, for instance, that they usually wouldn't say, and they're snapping at little things. Sounds like you're saying there is actually a real physical cause for this, and
yeah.
and they can explain that to their partner.
Because there's going to be a lot of conflict, usually in SIRS, in a couple of terms of executing a plan to get out of water damage, and remembering that each side's responses in this planning are not entirely rational, is important, to just have a lot more tolerance and even some laughter once in a while at what's going on. Yeah. I know sometimes I will just burst out laughing at some of the arguments I see going on, because I've seen them so many times, and it's the same thing, right, back and forth. and it's not going anywhere, it's not soluble, and it's usually regretted at some point afterwards. So I'll just sort of laugh and go, let's keep going.
Okay, great. So do you think sometimes one strategy can be for a patient with this condition to be able to name when they think they're becoming more emotional, or they're not acting in a characteristic way, to say, oh, here's my brain on fire again, or here's my mold brain again?
Absolutely. Hey, I'm sorry, when you calm down. Hey, I'm sorry, I really didn't mean this, you know? Let's take a time out, you know, that sort of thing. Let's go do something we like and not think about this for the rest of the night.
Yeah, I think that's very helpful. So I think it's worth noting that on this slide, around 13 to 19 of the main 36 symptoms which make up the cluster table, which is part of the way that we diagnose CIRS or CIRS, are neurological or brain related. So therefore, the brain is a very, very major component of this illness. Maybe roughly we could say half of the symptoms pertain to the brain. Anything you'd like to add to that, Dr. Ackerley?
No, just to emphasize that if you just look at this based on physiological symptoms, you know, you have the psychiatric, the mood swings, and I'd like to point out anxiety is not there. But my experience, and in many physicians' experience, anxiety is one of the most prominent symptoms. And Dr. Shoemaker said once upon asking him, he said he just didn't know how to measure it because it was so subjective. So, in my opinion, anxiety should be part of this too, as well as mood swings. There's all the focus, decreased word finding, concentration problems, ability to assimilate new information. Those are the cognitive issues. And then there are the more neurologicals. Light sensitivity tends to be a real symptom of neuroinflammation. And it's important to know that it's really, you see it even more in kids sometimes, is that sensitivity to sound, sensitivity to light, sensitivity to smell. Smell gets labeled as multiple chemical sensitivity. Other people's sounds, noises, and lights are worse. And it's neuroinflammation. It's a hallmark, and it's a good way to identify, oh, there's something going on. White lights really bother me now, or I just can't stand loud music, and the kids, you know, chattering or playing really gets on my nerves, etc. And then we also just have, you know, vision is actually a neurological function. So that's the blurred vision, and the visual contrast is when you fail it is a measure really more of neurological function, which I think has been covered here. There's, you know, the taste vertigo is another neurological symptom, and the thermal regulation that's often seen. Again, that's the hypothalamic pituitary axis, the increased urination and appetite swings. And so that's the HPA. And probably if you're good, you can make a, you know, case that the brain is involved in everything, pain, headaches, too. So the point of all of this is that the brain starts to get affected, and my guess for many people is what's first affected. And I think we're going to talk about that later when we talk about what happens to some people when they walk in water-damaged buildings and how they can use that to turn around and walk out.
Okay. Very much. So this is a, oh, we're getting some echo here. Not sure what's happening. Caleb, do I turn the microphone down or something?
Do you have another microphone, or do you have another window open with the actual live one?
No. Let me just try turning the microphone down a bit. Oh, here we go. I'll just use my other microphone. That's better. Is that better?
Yeah.
Okay, great. Okay, so in this slide, we have a NeuroQuant result. So many of you would know NeuroQuant is a FDA-approved program, or it's really a computer program which interprets the brain areas of, or it interprets the brain volumes, rather, of 11 different brain areas from a MRI brain scan. And it provides a table of numbers like this, which most of the Shoemaker certified physicians interpret through a little spreadsheet.
and come up with a score for CIRS due to water damaged buildings. And there are also some scoring indices which may indicate that tick-borne diseases may be playing a factor as well. But one of the big things is like, for instance, on this particular neuroquant, I'm sure Dr. Ackerley will notice that caudate is quite severely shrunken. It's about an average of about 0.16, which would you put that in the severe range, Dr. Ackerley?
Depending on the age, but yeah, it was certainly
fairly severe. And so what sort of symptoms would someone expect? And I think we're seeing a swollen forebrain and cortical gray here as well, which is classic of mold brain.
Absolutely. And also the cerebellum is a little bit on the larger size, something that interests me. And the hippocampus is a nice size, so that's not atrophied. Okay. So the caudate is the most dopamine-rich part of the brain. And dopamine, as most people know, is our passion neurohormone. It's or neurotransmitter. It has to do with pleasure and reward. And so obviously, if that starts getting smaller, there's going to be less ability for a person to experience pleasure in their life and reward. And one of the things most associated with caudate atrophy will be lack of motivation, because motivation is passion and passion is pleasure, and you have to get excited about things to want to do things. And what you see and what most people experience is life has become somewhat gray or a lot gray, and it's being run really more by what we call the amygdala, which deals with fear and survival and things you have to do. You have to pay your taxes. You have to pick up your kids. You have to do this. It doesn't have a lot to do with getting up in the morning thinking, wow, I can't wait to write that book, or I can't wait to go paint this painting. And most people just laugh at that thought because that's a long time ago. And so, showing any restoration there is going to change the, psychological experience of most people. Should also point out the basal ganglia, deficits in the basal ganglia are associated with Parkinson's, which is a disorder of decreased dopamine, and slowed movement is probably one of the first things we notice in Parkinson's, and tremor. And tremor can be seen fairly frequently in mold. And it's one of the things that brings people in too, is I have a tremor. I'm really worried.
Right. Okay, thank you very much for that explanation. And so it's a very interesting test, really, NeuroQuant, and it'll be interesting to see how the research on NeuroQuant develops over these next few years.
I'm sorry to interrupt.
No, you're right. You go.
NeuroQuant's being used in other fields. It was originally developed for Alzheimer's, and everyone who gets a NeuroQuant, will get actually, there's a sheet that comes age-related atrophy that shows, no, you don't have Alzheimer's. Just about everybody. I've unfortunately seen a couple where Alzheimer's was an issue, but it's also being used in other fields a lot, because the ability to measure the brain accurately, much more accurately than humans can do, is a very important concept in psychiatry and in neurology, in trying to figure out what is manic depressive illness, what is Parkinson's, etc.
I think one thing that's worth addressing very quickly, actually, Caleb, if you don't mind just going back one slide. A lot of people, Dr. Ackerley, who I speak to, when they see their NeuroQuant, it creates a fair bit of anxiety in them, in that the image of having a shrunken and swollen brain feels very scary to them, and they wonder whether their brain is actually beyond repair. Would you mind just speaking about that really quickly, as to whether the changes in the brain are permanent, or whether they can actually be totally reversed?
No, the swelling is something that seems to reverse faster in my experience when we do repetitive NeuroQuants. In the papers that have come out, that's something you see decrease faster. And I like to compare it to a computer. The hardware is still all there. It's just a little soggy, and we're going to try and dry it out. And that's a lot easier than replacing hardware that's not there. There's still a motherboard there. Atrophy is a little different, and VIP does seem to help restore growth in the gray matter, but gray matter atrophy is, a pressing concern in most of neurology as being associated with neurodegenerative diseases. So that is a little bit more concerning to me than swelling. And people often, when you say the brain is swollen, will go, yes, I know it, I feel it, I can feel my head. It's like it just wants to pop out, and I feel pressure, and especially pressure in the back of the head and headaches there. And it's actually confirming to people is this is not in my mind, this is in my brain. But it's a distinction between what's in your mind and what's in your brain. So there's a confirming part of seeing this too, and it's always relieving when you hear, no, you don't have Alzheimer's.
Okay.
In fact, usually the opposite pattern of Alzheimer's.
Great, that's very helpful. I also want to just very quickly mention the condition we call multinuclear atrophy. So some people have a neuroquant which has 3 or more areas which are atrophied or shrunken, and we often call that multinuclear atrophy. Would you be able to just briefly talk about what that diagnosis means, or what that term means, and is there any differences in terms of whether people's brain can recover if they have multinuclear atrophy?
I'm going to say we don't know the answer to the second part, because multinuclear atrophy is also associated with aging, and we're going to see more as people get older. And it's not necessarily Alzheimer's either. It does seem to be a factor in growing older. So the recovery we did see in the hippocampus is one of the places that's the one that's most associated with Alzheimer's, when that is 2 standard deviations below the cutoffs of the means for the age, and the ventricles are 2 standard deviations above. That's something we're thinking about Alzheimer's, and is pretty characteristic of Alzheimer's. And that one you can get better, and everybody is looking for actual reversal of Alzheimer's. That would be probably one of the most sought after things for many people is, again, if I die of cancer, I die of a heart attack, I go. But if I'm sitting in a nursing home for years with my kids, taking care of me, or having my diapers changed, please, and I'll hear many different variations on that. I don't want that to happen.
Okay, great. And just very quickly on the subject of Lyme, actually this patient, it's interesting to note their right thalamus is actually getting right up there, and which is the main, I believe that's the main area we look at for Lyme on the neuroquant. And so if someone does come up and there's some concern about the possibility of them having a Lyme-like illness, which is what we call it in Australia, how would you suggest that they proceed?
Okay. I think right now the criteria is that right thalamus is 0.61 or greater. I actually saw one the other day in a person who had 3 bands positive on their IgM Western blot, and I said, I think those ticks did have Lyme that bit you, and that was like, wow, I can feel comfortable. It is not a criteria for chronic Lyme. This was all done with acute Lyme, these numbers. So okay. I can't really tell people, does this mean you have chronic Lyme? What I can say is, your thalamus is really pretty normal sized here, right, and it looks like you have acute Lyme.
Okay, so neuroquant may not be as helpful for distinguishing chronic Lyme from mold. Is that what you're saying?
It's helpful to me because I get to see a lot of people who've been treated for Lyme for several years. They're not getting better. They hear about mold and they come for a consult. And I'll point out in a brain like this is, wow, you have some marked swelling here on the right frontal lobe. And you have some real atrophy of the caudate, and the cortical gray is swollen too. And this is, we see this in mold. That's a fingerprint. You already have 6 out of 8 here for SIRS, and I think it's certainly worth exploring the possibility that mold is either your main problem or keeping you from making progress in your Lyme treatment.
Okay, great. So looking at the biomarkers, and these are markers that we commonly check in SIRS patients or patients who we're assessing. It's a bit of an alphabet soup when you first get exposed to these terms, such as TGF-beta1 and MMP9 and C4A. but you've just got to hang in there and learn to navigate the alphabet soup. So these, basically what these markers are, we call them proteins which fuel the fire of inflammation in the body in our course. And what happens is that these proteins increase inflammation. And sorry, backing up a second, we get increased inflammation due to toxins into the water in water-damaged buildings, which then causes interstitial edema and can also cause leaky brain. And that can eventually, I'm actually missing the last word here. Hang on just 1 second. That can, Caleb, can you just read what is the last word on this slide? It seems to have dropped off.
Atrophy. I mean, eventually the inflammation will cause the atrophy that.
Causes atrophy. Okay, got you. And so the atrophy is, as Dr. Ackerley said, a more severe manifestation of inflammation in the brain. Dr. Ackerley, anything you want to mention about these markers specifically and how they actually affect the brain and contribute to the brain inflammation we see in SIRS?
There are several things. TGF-beta 1, by the way, is associated with Alzheimer's when they do spinal taps. And we know it certainly is playing a role in atrophy in the brain. MMP9 seems to cause more leakiness of the blood-brain barriers associated with headaches in the brain. And I'm going to say there's probably a lot more associations. They're just not as well researched in neurological and psychiatric literature as, say, other markers of inflammation. C4A is very exciting to me. I think people have heard me talk about it before, but in psychiatry, we have symptoms that we call schizophrenia, or we call it bipolar, and we think we're separating people out by the symptoms, and then when we go to look at their brains and their physiology, they look wildly different, and our diagnostic categories don't seem to make much sense. So it's very exciting that finally they studied about 60,000 people, I think, and found a genetic marker for schizophrenia. It's a big deal that this is the first thing in schizophrenia they found at the genetic level. And I was reading this in the New York Times last year thinking, wow, we finally got something in psychiatry that looks like science, and they're calling it C4, it's complement 4, and I'm thinking, wait, complement C4, is it RC4A? It is. This is the association finally found in schizophrenia, is a cytokine that we routinely measure in SIRS every day. It's an indicator that the innate immune system has been activated and about how much activation is going on. So what C4 does in the brain is something called pruning, and there was a slide a while back of a brain that was basically covered in shrubs, and you can see there's a little bit of pruning, and a little bit of pruning is necessary in any garden for things to grow. And it's the same with the brain, is that a little bit of pruning is associated with the cleaning up we do in sleep, for instance. So we start with a fresh slate the next day. However, you don't want the slate too fresh. And when the gardener basically, cuts away far more than they're supposed to and it takes the shrubs down just to the woody branches saying, oh, it's all going to grow back next spring. That's what's associated with schizophrenia, is C4A actively prunes and over-prunes in the brain. And there's some speculation that this is what's happening in schizophrenia. The gardener went, I won't use the word mad, I guess, but the gardener has been overdone it, and they've lost vital connections. The slate's become too fresh. So it's, to me, incredibly exciting is that there's an immunological basis linked to the inflammation we see every day. It's incredibly common, and I'm going to make the point at the end of this how common this inflammation is that has been linked to schizophrenia, and is the first thing in psychiatry really that starts to approach real science on the level of, say, where we see in cancer or cardiology.
Okay, great. So it's a little bit of a scary analogy to think that a gardener may have come with the shears into your brain. But the good news, it sounds like, Dr. Ackerley, is that the bushes can, to some degree, grow back if the gardener calms down a bit.
Absolutely, and I make that point is I wouldn't be doing this if I didn't see people getting better. And you know why? Because there's neurology, it's very hard to see people get better from neurodegenerative diseases. Psychiatry, they get better, but they're being treated for the rest of their lives with medications, and they don't really recover. I just thought when I found treating inflammation for psychiatric illnesses, people actually return to wholeness. I thought, wow, this is the best thing I've seen in this field. So that's why I'm here doing it. And that's why I want other people and other psychiatrists, neurologists to know about it. It's optimistic.
Absolutely. Actually, if we could just go back one slide again, Caleb, please. Just wanted to say very quickly as well, Dr. Ackerley, just so people have an idea of what levels of these markers might be associated with brain changes, would you say, just as a rough indication, maybe TGF-beta 1 levels that are above 10,000 and C4A levels around, that are above 10,000, and maybe MMP9 levels around somewhere above 500 are more likely to cause significant, or do you use significant brain symptoms, or would you use different figures?
No, well, yeah, I see people with significant symptoms lower than that.
Okay, right.
Yeah, but yes, that would be significant, and certainly very easy to make a diagnosis with those symptoms. I do see that people whose numbers are pretty low still have significant symptoms, and sometimes I'm going a little bit on faith that the numbers are low, but they are significantly impaired. And I think there are other things related to people's vulnerabilities too that make lower numbers as dangerous as higher numbers in some people.
Okay, well that's actually interesting, because I sometimes what I had been telling people, or my understanding had been, like, so for instance, if someone has had chronic Lyme disease and they've got, for instance, a TGF-beta of only about 3,000 and a C4A of only about 3,000, and maybe the MMP9 is only 380, I would say to them, look, I think you do have SIRS going on, but if you're really, really unwell, these levels may not explain the severity of your symptoms, and therefore you could have some ongoing infections. Do you agree with that thought process, or not so much?
Yeah, I'd say something similar. Is I'm a little puzzled because
Okay.
I do think you have SIRS, but something I see, I've seen a fair amount really with people with lower levels, is when you start binders, those numbers start coming up. It's almost like their body has turned off the mechanism. Still, you start trying to pull it out of the cell membranes, and it goes back to the bloodstream, and they start going up. And I'll usually get a little bit of relief with that. Is, yeah, I think I'm on the right track here. I think my intuition and the diagnostic and the symptoms, were right. And I'm actually sort of happy they're going up, although eventually we want them to go back down again.
Okay, well that's really interesting. And I also believe TGF-beta 1 and C4A can be suppressed by MARCoNS. So that could possibly be another reason that someone could be a bit lower than their symptoms suggest.
Yes, and I think one of the other SIRS doctors recently mentioned that she had found some research that there are certain SNPs associated with making TGF-beta, and she had a patient who was homozygous and really had low TGF-beta levels, even though they had SIRS. So there's more to all of this than we know now and may ever know. It's a very big field and a lot of things. So that's why, making the diagnosis really is based on the exposure to water damaged buildings, the labs and the symptoms, all of them, and a decline in health that's puzzling too. So there's an art to diagnosis and judgment calls that we're making a lot of the time.
Okay, great. Thank you. Thanks, Caleb. Okay, a little bit about starting to talk about treatment rather a little bit, and how people can start feeling a bit better from some of the brain symptoms, such as the brain fog and the anxiety. One of the first steps after removing oneself from exposure to a water damaged building is taking binders. These are a certain class of medications or supplements which actually bind onto biotoxins from a water damaged building. And the main one is cholestyramine, as most of you would know, which is often abbreviated as CSM. And I was just wondering, Dr. Ackerley, if you could talk a little bit about CSM, and also on the right of this diagram, we've got charcoal and well coal pictured, and maybe just talking a little bit about how these medications and or supplements can make people get some improvement with their brain symptoms.
You know, unfortunately, the only way we really have to get mycotoxins out of the body and get the inflammation down is using a binder. And people are sometimes surprised I don't have a magic pill or IV that's going to do this and it's over with. It's a long-term effort, especially since the fat cells in the membranes have been storing these toxins, and if exposure's been going on a long time, the fat cells have essentially been protecting the person by packing them in there instead of the brain or the heart or other places where they do more damage. So as we bind to the bile with cholestyramine and prevent its enterohepatic reabsorption, which is a really important thing to understand, we start to rid the body of some toxins, which enable the cells to release more toxins, and that's why detoxification takes time. Of all of these, cholestyramine is the strongest binder, and if people, essentially have pretty good guts and don't have a lot of GI symptoms, that's always my first choice. Unfortunately, people with guts that really work well are somewhat rare. And the next choice is going to be, and that would just be regular old Questrin. I don't like Prevolite. I don't like aspartame. I don't think we need to add any more toxins into a body. And so I like compounded cholestyramine for a number of people because I think the constipation issues can be less. There's just less there are no additives. Usually I'll use the stuff that has nothing in it but cholestyramine, and I see less problems with constipation, certainly a lot less problems with rash or allergic reactions, and people seem to tolerate it on the whole better. And if I have a sense people are sensitive and react to other medications, I'm going to go with compounded cholestyramine, which in the long run can be cheaper if it's efficient than trying other things that don't work. Welchol is a great choice, especially when people work, because it's much easier to take pills, and you can take them with food, and you can travel more easily with it. It's just weaker than cholestyramine, doesn't bind as much. On the other hand, when people are consistent with the treatment, we're going to get great responses. So if people are doing cholestyramine like once every other day, it's not very efficacious, and that's because you have to block the enterohepatic reabsorption, where 90% of the substances in the bile are essentially reabsorbed back into the body before they're finally excreted. And in that reabsorption, all we've done now is take toxins that may have been safely hidden away, brought them through the body, and are now pumping them back into the body so the rest of the immune system can start reacting. And it's not a great idea, and maybe one reason why people sometimes seem to get worse is they're being inconsistent. So I'd rather do like half a scoop of cholestyramine twice a day than a full packet once every other day. And that's a really important point to remember. So Welchol is a great choice. And then there are people who are just so sensitive, or constipation such an issue, that we start with charcoal, and I always tell people, yes, I've seen people get better with charcoal over the years. I think it is effective. It doesn't work the same as cholestyramine or Welchol. It's not as strong, but in animal literature, there's a lot of literature that it does bind directly to the mycotoxins and appears to escort them out, and people get better. So, and charcoal can be taken after meals. It helps with gas and bloating. It's used by every ambulance in the U.S. for poisoning and toxicity. And for some people, it works very, very well. So the choice of binder depends an awful lot on the individual. And you have better responses, I think, if you sort of gauge how a person's going to respond and start with the one they can best handle.
Okay, great. Yeah, thank you for that, Dr. Ackerley. So really, the use of binders is a very, very important step in the SIRS treatment protocol, and it can make people's brains feel a lot better. And it's important also not to withhold this, even if you're not totally out of a water damaged building. And that's an important little bit of mythology we're wanting to bust as well, that you don't have to be totally, I mean, of course it's better. It is preferable to be out of a water damaged building, but you don't have to wait for that step to have occurred for you to start taking cholestyramine or another binder, and you can still get some benefits from doing so. So that's an important point. Now, a little bit about MARCONS, which stands for multiply antibiotic resistant coagulase negative staph. Now, we all know staph is a very, very common bug, and it's associated with skin infections and bone and joint infections and things like that. However, in SIRS, there's a different type of staph that we look at called MARCONS, which gets in the nasal cavities. And there's a number of things we use for that, and we know that MARCONS can have a direct effect on the brain. So I was just wondering if you could talk a little bit about how treating MARCONS can also help people feel better in terms of their brain symptoms, correctly.
Well, we hypothesize, and there's some evidence now with Joe Musto's lab, that the biofilms which are holding the MARCONS themselves are making a toxin that's really quite toxic, neurotoxic. And again, given the proximity of the colonization of the nasopharynx, the jaw bones, and the nose itself, the sinuses with the brain, it's not too surprising to hear that MARCONS probably does affect the brain, and the impact of a neurotoxic substance coming from those may be why some people routinely say when we finally get rid of MARCONS, wow, that's made a big difference. I am a lot less anxious. That really feels good. I just feel so much better. And I've seen that enough over the years consistently to know that that's not a step I really want to ever skip. And it's worth persisting, going to the dentist, looking for cavitations, going through different sprays, knowing that we will eventually, with dental treatment, I'm going to tell you, as well as nasal treatments, get rid of MARCONS. And it's worth it, especially if you're again thinking, what is the effect of some neurotoxic substance on my brain as I'm getting older, etc. I think Bredesen has said there's definitely an association between poor dental health and Alzheimer's.
Great. Yeah. So MARCONS, treating MARCONS is a really, really important other step of the SIRS treatment protocol. And here is the full SIRS treatment protocol, which we also call the Shoemaker protocol. So we've talked about removal from water damaged buildings. We've talked about binding toxins with binders. We've talked about eliminating MARCONS. There are a whole bunch of other steps in the middle there in light blue, which we call hormonal and immune correction. We're not going to talk too much about them today. That includes things like DDAVP nasal spray and using either Actose or high-dose fish oil, along with a low amylose diet, and losartan is a medication that's used to reduce TGF-beta levels. But the cherry on top of the SIRS treatment protocol is VIP nasal spray. Thanks, Caleb.
Oh, right.
Oh, you didn't have another. Okay, so jumping onto the VIP nasal spray, and I think the research that Dr. Shoemaker presented in Irvine last year was very exciting, actually, in terms of the amount of reversal of brain shrinkage that one could achieve with VIP nasal spray. And it seems that really this is an extremely important step for reversing some of the brain changes of SIRS. Would you like to talk a little bit about that, Dr. Ackerley, and how you think this is beneficial in terms of people's brain and neurological symptoms?
Absolutely. I think, I try and get people to understand VIP usually comes at the end of treatment. Sometimes there are exceptions, but that it is worth hanging on for, because when you start it, for many people, they will say that is the most significant thing they've done. They're starting to again feel normal. One is its effect on the lungs and the ability to relax smooth muscles, take a deep breath again, to get more oxygen back in the body. It can help POTS in that way. Those are all very, very big deals. there's research on the brain that I get very excited about. It's been linked to, dissolving plaque, linked with, helping memory. It's been research for Alzheimer's. And I've had a number of patients over the years who say their first spray of VIP, they got the euphoria, but it stayed, and they've been depressed for a long time. And they finally started to feel again pleasure, euphoria. And that does happen, and the depression hasn't come back. And I'm not saying that happens for everybody. It's unique, but it's happened for enough people that, yeah, that one's worth it. For others, it's a slower haul. They may get more of a dysphoria in the beginning, and I've worked with a number of people where we just start at a very low dose, like a 1/10 dose, and work with getting a person to be able to increase ability to tolerate the detoxification. We think VIP is what's helping release or move some of that extra fluid from the brain back into the CSF and out of the body. So it's helping the edema. And sometimes that can be irritating before the brain starts working again. But it's worth sticking with. For others, it's a combination of having more energy and improved cognitive function, as well as perhaps even tolerating some exposure a little bit better, that makes it where you can begin to think, maybe I'm going to return to full health. So lots of things about VIP, and I think there's a lot more exciting news to eventually come from studying what VIP is doing in the brain at the genomic level, as well as the neurological psychiatric level.
Okay, great. So sounds like there's a lot of potential for improvement through the Shoemaker protocol. I'm just going to change my microphone here again. Encountering this problem.
Okay. So it sounds like that a lot of people can get really good improvement with their brain symptoms through all of these steps of the Shoemaker protocol, and that's really encouraging for people, because it can be quite scary. I think it's worth noting that at the start of having SIRS, just the amount of memory loss and impairment to clear thinking that occurs, but perhaps just knowing that there is a stepwise treatment protocol and that the brain changes can be reversed is somewhat calming for people, I guess. Dr. Ackerley, would you say?
It is, and then learning to identify re-exposure by some of the very quick reoccurrence of these symptoms. I've talked before about how people can walk into water-damaged buildings and really very quickly start to feel suicidal, and they were feeling fine beforehand, and learning to walk out and have it stopped. And every time I tell it to a new patient, it's like, yeah, right, And as they get better, and then suicidal thoughts reoccur, and they will begin to realize, wow, these things I consider meaningful. The fact that I want to, hurt myself in some way, it's coming from a chemistry, it's coming from inflammation, it's mold. I call it black mold, black thoughts. That's what happens. And, and it can reverse as quickly as turning around and getting out of the building, maybe wiping off your nose, taking a swig of cholesterol, going home and showering, things like that, and nobody believes it till it happens to them, and they go, oh my God, So that's a light bulb for a lot of people, that thoughts and feelings they consider real are based on black mold, black thoughts. And so that's a big deal, and that's where Brain on Fire has been helpful to a lot of people to just realize this isn't you. You don't have to act on this stuff, and you can get better, like turning around and just looking up at the shower and realizing, oh my God, there's black mold right on top of me as I'm sitting here thinking about, ways to kill myself. So that's being frank. So that's important to know that can reverse and stay reversed and can then be used as a warning sign. For some people, it's not as dramatic. It's irritability, anger. Things are happy, you're getting along with your spouse, you walk into a building, and all of a sudden, every rotten thing they've done is just right there at the tip of your tongue. Think about it for a second, and realize, wow, we're at each other's throats, what happened, and walk out, and you can find the pleasure back in life again. These things are real, and I suspect they happen to a lot more people than people who are treating for SIRS, is that the irritability and arguments we see going on maybe, due as much to, presence of environmental inflammagens as they are to the reality that there's an endless war of the sexes, et cetera. So I think that's optimistic to know this. So other things we can do, certainly diet. I like anything that's basically going to be low carb, paleo, below 50 grams of carbs when I'm asked. Anti-inflammatory. I don't like gluten. I don't like dairy for most people. But I, try and work where people are, but just realize that in my experience and most people's experience, those are the two of the most common allergens and inflammagens, and they are making things worse in the brain. So the diet alone, the anti-inflammatory diet, if you're going to go on some sort of treatment for Alzheimer's or pre-Alzheimer's, it's going to be a very low-carb diet, and lots of aerobic exercise are the mainstays really of the medicine protocol. And it's the same thing for SIRS, I believe, that getting rid of the inflammatory components of your diet can't be overstated how important that is, and important for your lifelong brain health. So it's a big deal. Fish oil, I really like fish oil. There's so much research on fish oil in psychiatry, how incredibly useful it is for inflammation. And inflammation, by the way, turns out to be a very strong factor, not maybe the only factor, in every psychiatric illness that's studied. So when we're asking what causes this stuff, inflammation plays a major role. And you'd hear more about it if the drug companies had better anti-inflammatory medicines for the brain. In fact, they've kind of given up developing really new antidepressants because they know that anything they do is only going to get about 50% of people better if it's along the neurotransmitter route. So things you can do without drug companies really are fish oil, curcumin, NAC, all of them very well researched at this point in psychiatry and in neurology as the supplements probably most linked with helping inflammation. Magnesium, hopefully that's on everybody's list and is getting measured and treated because it's such a common nutrient deficiency, and treating that helps anxiety pretty quickly as well as blood pressure. Probiotics, vitamin D, to me, that's kind of normal.
Yeah.
There are very few people who don't need those. So, and the other things that I think are important are counseling and therapy can always be useful as long as the person you're working with accepts that you're not psychosomatic and that mold illness or Lyme or that neuroinflammation is real. If they're kind of undermining everything said, that, nodding and winking, move on. You can definitely find people. I certainly know people and do others who are psychologists, have had mold themselves, and are very happy to work with other mold patients. And very helpful in many aspects of all of this. Relaxation, yoga, eudaimonic happiness, these things have all been shown to decrease inflammation at the genetic level, and turning off the inflammatory epigenetic at the epigenetic level is going to work far better than just working SNP by SNP to try and correct each SNP. As you can turn off the whole epigenetics with inflammation, you're going to get a lot more done. And then I do mention limbic retraining, and a lot more these days to people. It's called dynamic neural retraining. It's a course that's easily available on DVD. And it is for training that amygdala. It's for training the limbic over-responsiveness that many people start to develop somewhere along the line, either in this illness or for other reasons. They're in what we call sympathetic overdrive, and everything has become a fight or flight situation. And relaxation, which is where healing takes place with vagal tone, is very hard to achieve. And I think it can be summed up is, when your mind is not your best friend, you're really in trouble. The mind is a very powerful part of healing. And when it can be your best friend and coach you and encourage you, it's terrific. But when it's gone into hyper fear mode and it's seeing, fearful situations and everything new. It's an overdrive, and it's really your worst enemy at that point. And I've had one physician say, who's a surgeon physician, saying, I think it's better than cholestyramine. For some people, it's going to be the only way really we even get them to cholestyramine is to start turning off the fear response to everything new. And this does seem to really work. And I've seen it work now dramatically in a couple of people who stick through it. And well worth investigating if you turn around and say, you know, my mind really is my worst enemy. And if there's something I can do about it, terrific. So I think the one other point I want to make as we close is that I am very passionate about getting other psychiatrists, psychologists, neurologists to recognize, family practitioners, how important inflammation is and what they're labeling depression and anxiety. Depression and anxiety, it's about 25% of the population that said to have mental illness, a word I hate. And, you know, that's about the same percentage we say is influenced by mold. Interesting coincidence. But we don't have that really effective treatments for depression. By 2030, who says it's going to be the leading cause of disability worldwide? Obviously, if antidepressants did what their name said, it would not be the leading cause of disability. But psychiatry has made no progress really in the last 30 years in actually reducing the amount of illness, of psychiatric illness in the world, while we've made big strides in infectious diseases, cardiovascular, cancer, things like that. So learning about the causes of inflammation and learning that mold is a very common cause of neuroinflammation is really important to me. And, you know, anyone else you can educate about it or just learn it yourself and start to, you know, treat your own depression and anxiety is a big deal. And Alzheimer's, you know, that is becoming an epidemic. People will use the words epidemic as more and more boomers are reaching Social Security. And that's a pretty fearful thing. And if there's something you can do to prevent it by fixing the roof, fix the roof. It's worth it. You know?
Do you have time for some questions, Dr. Ackerley?
Yes, of course, yes.
Okay. There's some good questions, as always, from this community. This is one from Dana, wondering how we can distinguish between autoimmune encephalitis and mold illness.
That's a really good question. Autoimmune encephalitis is pretty rare and actually somewhat hard to diagnose, even if you might suspect it. I know it's gotten a lot of play in books, but it's much, much rarer than just mold illness. And as you know, mold is also what can certainly contribute to turning on the whole autoimmune response. So in terms of symptoms, don't really know. Laboratory testing is where you have to go for that. And also oddness of symptoms. So hallucinations are relatively rare. In mold illness, they do occur, but if someone's having, you know, unusual musical, auditory hallucinations in the absence of other things, I'd be thinking perhaps more autoimmune, or hallucinations just really coming up out of nowhere. But again, it's going to be called schizophrenia or bipolar pretty fast. And you're looking for things like SED rate. There are things you can look for in autoimmune. So even knowing about either one of them would be welcome in the world of psychiatry in an emergency room where people are seeing them.
Okay. There's another question. If one finds patterns of mold and Lyme in the neuroquant, when specifically is Lyme treated in the protocol? After avoidance, after binders, after Marcons, or after VIP, or somewhere in the middle?
That's a really good question, and probably depends on the physician and the patient. I think acute Lyme, if you find it, should be treated right away. I mean, if you have a chance to actually prevent it from developing into chronic Lyme, by all means, treat it right away. If we're talking chronic post-Lyme, I often recommend patients get out of exposure, and start treating for mold and see in the protocol, are they getting any better? Are things developing? And for so many people, they start to get a lot better, and the idea of post-Lyme kind of fades in the background. It doesn't happen for everybody. At some point, it becomes obvious the joint pain is not going away, and we're going to treat Lyme or test for it more robustly than the usual screening test we use. So I think that's pretty individual, but getting out of mold exposure if you're undergoing Lyme treatment is a big deal, is going to make things much easier.
Okay. Could Dr. Ackerley please comment on the increased size of the cerebellum and any effects this may have on the ability of the brain to cope with the SIRS protocol?
What I see, what I've talked about, is that more commonly that large cerebellum, which is at the back of the brain, and is going to, we presume, decrease the ability of the CSF to flow easily out of the brain, does contribute to making VIP in particular harder to tolerate, and may actually even make binders harder to tolerate, again, because we're going to be pulling toxins. So when I have hypermobile people and I get neuroquants pretty early in treatment and I see the cerebellum's really big, we'll talk about it. I actually love craniosacral treatment and lymphatic drainage as a treatment, which is A, not going to hurt anybody because it's pretty pleasurable, and for many people becomes almost life-saving because it helps vagal tone tremendously. That's documented. If you find someone who's pretty good at it, especially DOs who are really good, it starts to readjust the face. I wish I had with me, someone just showed me with a large cerebellum, someone actually in treatment for Lyme far longer than they should have been, who started to get better when mold was mentioned, who found a DO. She showed me her face from last year was kind of swollen with the mold facies. And she's been getting treatment for 3 months, and her face now looks like she had a facelift. There's no swelling. The cheeks look good. It's like, wow, that's just from craniosacral or DO. And she's getting a lot of relief from headaches and brain fog from that. So I like to mention that that's a way that there seem to be treatments that help increase that drainage. That can be done independent of the protocol. And for patients who we're really having a hard time getting detoxification started, I just like what I call manual drainage, which is going to be craniosacral, lymphatic, colonics, things like that, that just open the lymphatics, open detoxification of the gut, and can help a patient begin to tolerate some detoxification. If everything's clogged and you start now demanding the body detoxify more, it doesn't work very well.
Okay.
So do you mind if I jump in? I believe you mentioned CBD oil at the Irvine conference, Dr. Ackerley. Is that something you think, you still feel that that's a useful strategy, people with cerebellar swelling?
Yeah, and for others too, but certainly with large cerebellums, it has evidently a lot of cannabinoid receptors, and I rarely see bad reactions to it. People sometimes say it's not doing much, but others just even a few drops, and these are the people, a few drops of anything makes worse, are like, wow, I'm sleeping a little better, my pain is better, and not really negative stuff, anxiety. So I think it's absolutely helpful, and it's fairly easy in a number of states. It's legal in every state, but in some states it's even easier to get, and it's certainly worth trying.
Okay. Actually, I had a very quick one, Caleb, if you don't mind me jumping in here, which I think is a very important thing to mention. Pyrrole disorder. How important do you think it is for people to look into and be diagnosed with pyrrole disorder if they're suffering from anxiety and depression and mold illness? I
test everybody for zinc and sometimes copper, but always for magnesium and zinc. And I make an estimate when people's zinc are below 1,000. I get them at 700, 800. Red blood cell zinc is, we're probably looking at KPU, especially when I start giving zinc and it's not going anywhere. So I think it's obviously important. It's a long-term, it's not a fast thing to correct. And again, a lot of, I think Klinghardt, who knows the most about it, probably has said it's, a product of chronic Lyme, chronic mold, chronic infections, and so we're treating all of it, but I am always using treatments for KPU if I think it's present.
Yeah. So just to explain for those who are not aware of what KPU or cryptopyrroluria is, it's a condition that was described by Abraham Hoffa in the 1960s. There's a certain substance which we call urinary pyrrole, which is created in the blood of people who are unwell. And we don't know why people create this substance, but it's created in the process of red blood cell production. And importantly, it causes people to excrete more zinc and vitamin B6 in the urine. And there's also some other nutrients such as biotin. And as a result of that, what happens is people tend to get an excess of copper, and that tends to increase adrenaline and noradrenaline, which can increase anxiety. And the low zinc and vitamin B6 can lower serotonin. So in my practice, I found that to be an extremely important cause of anxiety and depression problems. So I thought that was an important one to mention as part of this call.
If you're going to bring up Abraham Hoffa, I'll make one point too, is he was, I think, one of the first to actually popularize histamine, along with KPU, as a major cause of psychiatric illness. And unfortunately, he was pretty well laughed at, including by someone like me who was trained at an institution that loved to make fun of the histamine theories. Well, it's actually turned out that histamine is a major player in neuropsychiatric symptoms. Certainly anxiety, bipolar schizophrenia, depression, as well as brain fog, as well as probably contributing to all the neurodegenerative sorts of things we see. So the relationship of histamine and SIRS appears to be there. And water damaged buildings certainly do seem to destabilize mast cells with the innate immune system, and turning off exposure probably helps what we're calling mast cell now. But I will say that I've become more and more to appreciate that histamine is a major player in what we call reactivity. In this protocol, there are people who react to everything. And VIP is not working, things aren't working, is that starting to look at mast cells in treatment can be quite successful. And I like to do that in working with allergists locally who also look at that. And I'm very lucky in Tucson, we have a geneticist who was really good and taught me a lot about Ehlers-Danlos type 3, which is certainly more common in the people I see and more common in the SIRS population. And someone who, also works with mast cell syndrome, not the disorder, which is different. And it's learning those things and learning about POTS that I think start to get a little bit deeper into this whole protocol of what people need to do to calm down what we're simply calling anxiety and depression. But histamine is a very big player in neuropsychiatric symptoms. Based on research, not just based on me saying so, but just based on actual research, it does bad things to the whole microglial system.
There's a few people asking about low-dose naltrexone and the SIRS protocol.
It's certainly fine. I use it whenever anybody asks me, or when they actually have autoimmune illness, or when I see that, hey, maybe the depression, which is sort of low grade, might be helped with it. It helps insomnia, it helps pain, it helps certainly autoimmune issues. And I have a couple of patients diagnosed MS in whom low-dose naltrexone, they could tell majorly when they started that it was helping their symptoms. So there's really very little drawback associated with trying it. And you can also take it in the morning if it's keeping you up. That's the whole idea of only taking it at night seems to have been debunked, and absolutely worth trying. It's inexpensive and got a low amount of side effects.
Yeah. More questions, Caleb, or did you want us to talk about the course?
Maybe one or two more questions.
Okay.
Does VIP correct the neuropsychological issues unique to SIRS, or do the sleep issues, anxiety, depression, etc., require independent treatment?
That's one of those questions that's probably best answered on a case-by-case basis. Yes, sleep's incredibly important, and that's something that I will work on in the protocol independent of where people are. If they're really not sleeping, there are hormonal things we can do, or sometimes medications that will make a big difference in sleep, and getting sleep is really important. What were the other ones besides sleep? The neuropsychiatric stuff. You know, there's a whole contingent of people who are kind of depressed and anxious when you ask them, but they're kind of quiet about it. They're not making a big deal about it. You go along in the protocol, and all of a sudden you notice one day they're coming in, they're kind of smiling, they crack a joke, and it's like, hello, are you feeling better? And yeah, so we haven't really labeled them depressed or anxious, but they've had those symptoms, we'll acknowledge them, and they're getting better without really treatment or focusing on them. And that happens for a lot of people. If depression or anxiety is basically the overriding symptom, depending on the severity of the depression, I am still going to offer antidepressants. They do work in some people, and it's worth trying, especially if someone is seriously depressed. And we're talking about hospitalization, which has had to happen for a couple of people at points. And benzodiazepines, I think, you know, I don't like the dependency aspects, and there are supplements that can really help increase GABA, but I'm not shy about using them in people who are having severe anxiety, again, which is interfering with treatment, interfering with sleep, and it seems that getting that rest or getting GABA better under control is really helpful. And so I think there's a real role, and I don't have people having very many bad reactions to benzodiazepines. When they need them, they work, as opposed to antidepressants and other psych meds, which tend to make things worse a lot. No. So again, it's individual depending on the severity, depending on how well people tolerate things as they're able to get better. The whole Ehlers-Danlos, POTS, sympathetic overdrive, those are the people who may benefit the most from anything we can do to calm down the pulse rate and calm down sympathetic activation.
And have you used Epsom salts baths as just a little additional thing people can do to...
Always recommend it. There is no contraindication, and even people who feel that they have SNPs that don't tolerate sulfur often do fine. There's magnesium and sulfur, they're both needed, and taking a warm bath before bed instead of watching a computer TV or fighting with somebody is really a good idea.
Right.
So, yeah, so no, that's like automatic. It's absolutely go for the Epsom salts. Dead sea salts have a few more trace minerals in them. Is, you know, don't hold back.
Great, thank you, Dr. Ackerley. So, Caleb, shall we go into the course and just very quickly to go into the course? We're probably taking up a lot of Dr. Ackerley's time here. So I just wanted to close by just explaining a little bit about my course. And, you know, this is a tiny bit commercial, but I really, really do believe this helps people. And I believe it's very important because I think it's vital to understand the illness that you're suffering from and to gain clarity and confidence. And this condition is extremely complex, or it can be made extremely complex. And I created an 8-week online course to help people, as much as anything, just to feel less anxiety around the condition and less despair around whether they could get better. And I see that in a lot of patients. You probably do as well, Dr. Ackerley. It's
so much, yes, so much so that, let me finish the commercial for you, is I recommended to our local Tucson group that they start using it. In fact, the leaders bought your course and they're studying it one module a month. And I'm finding it helpful that I'm getting more questions, a little more fact-based from some people. There's sometimes a tendency of people, again, to have problems, you know, figuring out who that they're reading knows what they're talking about and who doesn't know what they're talking about. And your course is just really helpful. And hey, here's what we know. This is the facts of the protocol. This is what the protocol is. This is why we're doing it. This is what we expect. Just even the simple question that's coming around a lot recently, I can't take cholestyramine until I get out of a water-damaged building. Well, if that were part of the protocol, we wouldn't be treating 50% of people for the first year or maybe 2, because it's that hard to get out of water exposure for some people. So no, totally false, and one of those things that really would hinder anybody who believes that from getting better. So having some factual-based resources is real important, and as I say, the group here is doing it. They like it. People are wanting to attend more to listen to it. So that's my recommendation.
Thank you. Yeah, thank you, Dr. Ackerley. And I think there is a little bit of a risk just using the online support groups, such as on Facebook, even though there are some excellent people like Caleb on there who are giving good information. Of course, there's all sorts of people who are chiming in there, and the quality of information is variable. In this course, I believe the quality of information is excellent, and you can rely upon the information. We talk about how to screen and diagnose SIRS. We talk about the Shoemaker protocol in depth, what the steps are, what are the medications, how to tell if a building is a water damaged building. And these are big questions because remediation is a big deal. And the decision making around that can actually be very expensive if you make mistakes in that area. And therefore, I believe that's probably one of the most important areas, also to make sure you get a good remediator if you're remediating your building, because not every remediator is going to be at the standard that you require to recover from SIRS. And if you just get that one point out of it, I guarantee that the course is worth it.
Yeah,
just for that one little thing. Delving into each biomarker, we talk about C4A, we talk about TGF-beta, we talk about MMP9, and we talk about the normal ranges, which laboratories should you do, what they do in the body. Again, we can we help you through this process of deciphering the alphabet soup. Where to send patients if you yourself do not have a Shoemaker certified physician. We help you to navigate which ones have special expertise areas. So Dr. Ackerley is a psychiatrist, Dr. McMahon is a pediatrician. So we are getting a growing number of specialists who actually have special interest areas. We have certain of the Shoemaker certified physicians who have an interest in Lyme disease. And in the course, we go into that a little bit more that then you'll find on the website of Surviving Mold. We talk a little bit about building remediation, including the do-it-yourself remediation and the science on that. We talk about other sources of biotoxin exposure, such as Lyme, Babesia, Ciguatera, and algae. We talk about the Lyme controversy, and I'm not going to lie and say that that's a simple thing to navigate. It's not. It's quite complicated and confusing, and I believe the course makes it as simple as possible, and to really just understand why there's such a big difference between the ILADS and the IDSA perspectives, and how to understand the difference on Lyme disease. So there's a website at moldillnessmadesimple.com, which you can check out. But once you sign up, you get access to all of the materials, which includes 18 video lectures and slides, a workbook for each chapter, weekly quizzes, exclusive webinar archives. So, for instance, the previous webinars, such as the one we did with Dr. Sonia Rappaport and with Dr. Samantha Clark and so on, they're all on there and you can access them. And we also have a private Facebook group where people ask questions, and I go on there regularly. Caleb's on there regularly. Other people who are very, very experienced in this area are answering questions. And there's a degree of peer support on there, which is rather nice, actually. So you can see these are an example. Sorry, just go back to that slide for just a moment, Caleb. Yeah, just so you can see that's an example on the left-hand side of this slide of what the PowerPoint slides are like. So, for instance, the concept of cytokines is quite confusing and it's quite hard to get your head around, but we make it as simple as possible by explaining that they are chemical messengers or proteins used by immune cells to communicate with each other. So as you can see, we make these basic concepts understandable. And if you can get the key basic concepts, you can understand this illness. Thanks, Caleb. We do have a discount code for this webinar for people who've come along to this webinar, and it's Brain on Fire. which is named after Dr. Ackerley's article. And so the course is $149.25 for the next 48 hours. Look, I really do believe it's worth it. It's a very complicated illness. If you can understand it, and if you can gain a level of confidence over it and understand the steps you're going to need to take, it's much more likely you're going to hang in there and not drop out of the process and get yourself well. And that's my passion. It really is. I really don't like seeing people who get overwhelmed and depressed and get stuck there through this illness. I've recovered from it myself. I'm not sure if you're aware, Dr. Ackley, that I had it myself and recovered. And
that's a great example. Is yes, people recover every day from it. And
that's right. And there are other recovery stories around the world.
Lives. Yeah, and don't identify as mold survivors particularly, but just try and help others identify and recover too. That's quite possible. I was going to say, if people learn this in depth, I'm hoping they might even get interested in research themselves at some point, or real research, or going on careers, or getting involved professionally, because it's that kind of awareness coming from the ground up, which is happening, that's beginning to turn the academic establishment to have to pay attention to this very common and sometimes very devastating illness. So
that's right.
That would be my wish.
That's right, and I just want to just close by saying a few things from the heart. That if you can get through this illness and get to the other side, there are really good things on the other side. I believe this can be an amazing growth journey for you personally as individuals. I know that sounds difficult to stomach if you're right in the middle of this at the moment, but I definitely believe that, and I believe that there are really good things on the other side in terms of you being able to then jump into another life purpose or a deeper level of life purpose, if you like. And I've seen that happen in a number of individuals, and I believe it can happen for you. Dr. Ackerley, anything you'd like to close with?
No, just thank you. I've seen the same thing. I have a few patients who've become real advocates at different levels, more pediatric or adolescents, of getting doctors and professionals to pay attention to the fact that not every adolescent who's suicidal just needs more antidepressants, but may have mold, may have Lyme, may have Babesia Bartonella. Is that the more awareness that's brought that these things are real and really do cause illness, first seen in adolescents, usually in the neuropsychiatric realms and not in the rest of the physical realm, is going to help save a few more lives from endless, bouts of depression, maybe actually committing suicide. That's an enormous big deal, is if you can do that for others.
Right,
thank you, Dr. Gupta and Dr. Ackerley, for your time today. And thank you for everyone who joined us. A replay will be available, and that'll be going out through the mailing list and Facebook groups. But thank you again.
Great. And I also just wanted to very quickly express my gratitude for Dr. Ackerley's contribution to this field, including her research she's done on VIP and NeuroQuant and Marcons. And I think it's making a real difference for this whole field to move forward and for us to help patients. So thank you for being on today. I really appreciate it.
Okay. Thank you. And happy Memorial Day for everyone in the U.S.
All right. Great.